All right. Hey, everyone. Welcome back to Basically EMS. Chris here with my man Wade.
Hello.
And so real quick, if you're watching this on YouTube or listening, whatever, historically, we've been doing this under the Summit Healthcare Education page. It's kind of our main gig. But we're going to start to move Basically EMS into its own YouTube channel. So if you're watching this, we'll be cross-posting it on both channels, at least for a little while. But go and check that out. We'll put the link up so you guys can see that channel. We're going to put all the old Basically EMS stuff on there. We're going to start to post there. So please go check it out there. If you're a YouTube watcher, subscribe there and all that. That's where all this stuff is going to be going forward. And so we have some other kind of fun little ideas of things we can do once we have our own channel. So keep an eye out. Should be cool. Should be
pretty excited.
Yeah. Today, though, we are going to be talking about orthopedic injuries.
Orthopedic, if you read it.
Orthopedic?
Gallically. No, I don't. Orthopedic.
Yeah, orthopedic.
Yeah.
So we're going to be talking about orthopedic injuries. It's a pretty massive subject. So probably going to have a second episode on this. I think we've been discussing before. So, keep an eye out for that maybe down the line. I'm assuming we're not going to get through everything we'd like to talk to today. So,
yeah. And realistically with this topic, it's not so much like, yes, you need to know individual things, but there's a lot of like concepts that start to really apply when we talk orthopedic.
Yeah, which will probably be more today, kind of general concepts, and then we can have something that's a little more specific about these injury types and that kind of thing. We might do a little bit of that with like hip fractures and the more common life-threatening we really need to be aware of, but maybe not super in depth in like elbow injuries or something.
Right.
Yeah.
Right.
So starting off, obviously if we're talking about orthopedic injuries, those are going to be kind of bones, skeletal muscles, ligaments, tendons, all that kind of thing is the kind of injuries we're going to be talking about here. So, for the EMT level, having a baseline understanding of most of the major bones is important. You don't need to have all 206 bones memorized for sure. Which I don't know, you might have had to do that in your schooling at some point. But
Once upon a time, yeah. And then like the different like condyles and attachment points. We don't need to know that at this level.
No, yeah. If you know that the arm has the humerus, the radius, and ulna, which ones those are, I always remember the radius is rad. So thumbs up, radius is rad. If you remember that, and then that the hands are going to be the carpal instead of the tarsals.
Yeah. You don't want to hear mine on that one. It's because they're your car pals because you drive with your hands.
But you also drive with your feet.
Car pals drive with your hands.
Cut that out in the edit.
Yeah.
But yeah, so those kind of things, and then maybe the bones of the skull is always good.
Yeah. I think that one's better mostly if we think about it from the perspective of, if you know the bones, you know the lobes of the brain, and so there's a lot of crisscross, so it kind of makes your job easier.
Yeah. But yeah, so if you're, a student listening to this, you shouldn't have to know the names of all the different tarsals or anything like that.
No.
But you should know, femur, you should know, that kind of those major bones, right? So it doesn't need to be that in depth if you don't want it to be at this level, but make sure you at least know like the basics of it, right?
Right.
If a gym bro knows it because they know the muscles and all that, that's kind of, to me, that's always been the level, right? Like you should know the muscles, major muscle groups are like a gym bro knows, and you should know the skeletal bones that are connected to those essentially.
Yeah. You need to know enough to understand if they point to a specific area, what bone should be there. And that's kind of really where it ends.
Yeah. Yeah. And then talking about orthopedic injuries, generally these are going to be not life-threatening injuries, but very common injuries that we're going to see. And we'll talk about it, but a lot of this is really about like, what mechanism does this injury imply, and what else could be going on that I need to be aware of?
Right. Reading that transfer of force.
Yeah, exactly. So somebody has, I think earlier we were talking about like a scapulary injury, right? A broken scapula, that's a high mechanism. And what is the scapula protecting, and what could have happened beyond that? So, somebody, like I always use like the skateboarder that rolled their ankle and broke it kind of injuries, or we're probably not too worried about it, but orthopedic injuries and like a multi-systems trauma, that usually can be, if not concerning on its own, there's some concern about what injury or what force was impacted upon the body that caused that injury, and where else was that force
Right.
you know,
And
but
eventually you got to think about it too, is like if someone had like a broken wrist, that's not going to be a true life threat isolated. But if someone was in a, a crushing car accident and they have broken wrists and broken ankles, that's compounding still, right? Like it's not a massive amount of blood loss, but it's not doing you any favors
Yeah.
when you're treating these people.
or they have the broken ankles, the broken wrists, and a broken femur.
Right.
Like, it can definitely, impact a larger system, even though it's a smaller part of it for sure.
Yep.
And so like we were saying, a mechanism, and make sure, and this is such an important thing to understand at the EMT level, what mechanism is, and how to kind of assess for mechanism, right? So if you have these patients, if it's a fall patient that broke their arm, what height did they fall from? How did they fall? Were their arms out? Did they fall arms in? Those kind of things. When we're talking about orthopedic injuries, it's really a lot of it is just like we were saying, just do that good assessment on the mechanism, and don't let that information go unfound, because maybe you're not going to be able to find it again, right? Like I always preach this with like car accidents. The doctors are not going to see the car. We are the only ones typically that will see that vehicle and can recognize like, oh, that steering wheel was bent. Even if you take a picture from the outside of the car with your phone and show it to the doctor, which generally you're not allowed to do. But even if you did, you work in a system that they can't see inside to see what the inside looks like and see that bent steering wheel and all that. So
starred windshields and
all that stuff. So it's a really important thing for us to assess for that mechanism to see, okay, is it just that somebody tripped on a second stair and fell down? Not a big deal. Or maybe is there more going on with these things?
Yeah. And this is all trauma. And I like to break it down. Like when we have trauma, there's kind of two big deviations or delineations. There's going to be blunt and penetrating trauma. I have the very specific story that comes to my mind, but blunt trauma is not all created equal, right? Just because they got hit by something, don't expect it to be like, oh, they got punched in the face every time, right? Blunt trauma can be extreme sometimes. So just keep that in mind, right? If we're talking mechanism, it's usually going to fall under blunter trauma, but that's only like a third of our battle. So just hold on to that concept while we go.
Yeah, that's just kind of really, black and white definitions. Like penetrating trauma breaks the skin, blunt doesn't, but that doesn't mean that a blunt injury is any less than a penetrating injury for sure.
Right.
Or necessarily the penetrating injury is going to be worse, could just be something, I could stab you with my pen right now and cause a penetrating injury because it breaks the skin.
I had a patient got stabbed with a broom handle.
Oh.
Yeah, his girlfriend caught him cheating. She unscrewed the broom, like the tip of the broom off the handle.
Wow.
Got him with the old, perfect circle punch into him. Penetrating trauma, not really a life threat at that point.
Yeah. And flip side of that, I had a patient with a femoral bleed from like a 3-inch pocket knife.
Right.
I think I've told the story on the podcast before, but they were practicing their knife defense moves is what
I have not heard this story.
No, they were practicing their knife defense moves on each other, and somehow she got stabbed in the thigh. And we got there, fire department was already there. They actually just used an Israeli bandage, and that stopped a femoral bleed, which I thought was pretty impressive. But they told us like, oh, it's squirting when we got there. And we were like, oh, okay. Well, they were already wrapping it up. So wrap it up. We go to the hospital, take her in, priority trauma, because it was penetrating trauma above the knee, which is our protocols here. And I remember the hospital was like, bro, really? Because I don't think we had the knife, but I described, we saw the knife as, 3-inch little Swiss Army knife. And they're like, come on, really? Femoral bleed, whatever. And like, oh, I'm just telling you what was seen on scene. And they kind of laughed at us until they took the bandage off and she moved and popped the clot and it squirted up to the ceiling essentially, because it was a legitimate femoral bleed. So
she's not very good at defending herself with knives. That's what I'm learning from the story.
Well, based off of other factors, I think that's actually what happened? Probably not. That's the story that we were given.
Gotcha.
That they were practicing their self-defense moves. But I think that there was probably a lot of drug use involved in that kind of situation. So
that's fair. That's fair.
It was interesting. But it was funny to watch the hospital kind of freak out when she started squirting blood from her leg when they didn't believe that that it was a femoral bleed. Way off topic there.
Yeah.
It's been not even orthopedic injury at all, actually.
No.
But point being, right, like, and that's why that assessment is really important. Mechanism can lend itself to you thinking about bigger things, or it can also, the hospital just heard the mechanism, was like, oh, it's not a big deal, which was not the case. So make sure you're doing a thorough assessment and treat your patient, not your mechanism, a little bit too.
Right. I also think, last topic on mechanism before we dive into it is like, if based on your call notes, the mechanism sounds bad, you should kind of preemptively be like, okay, maybe I need to treat for shock pretty dang quick. Like if we get, dispatched to an ejection vehicle, motor vehicle collision versus like a fender bender, if I hear someone got thrown from a car, I'm probably thinking, okay, shock treatment, we're moving quick.
Yeah.
Right. So I don't want to say like Chris said, don't treat your mechanism, treat your patient, but let the mechanism guide you a little bit if you need
100%. To. Yeah. Yeah, for sure. For sure. So let's talk a little more specifics about just generals with orthopedic injuries. So fractures are going to be the big one, right? And that's just a break in the bone. That there's all sorts of different fractures, which we will come and talk about here in a second. But it's just some sort of break in the bone. Doesn't mean it's completely displaced. Doesn't mean it's a thorough fracture. But there's the hairline. There's the incomplete fractures. But it's some sort of it says a break in the continuity in the bone, the notes that we have from the book. So, and that's going to be any bone, any place is kind of susceptible to having a fracture.
Right. Have you heard before people are like, oh, I didn't break it, it just fractured. It's like, it's the same thing. I didn't pull my muscle, I just strained it. That's the same thing.
That's also the same people as like, yeah, I broke my elbow. Well, your elbow's a joint. So how'd you break that? You break a bone, not a joint, right?
Right.
Yeah. Similar things. You'll never watch a TV show the same. You'll never talk to people the same after doing this job for sure. Because you hear those and be like, come on, bro.
I can't say puke anymore. I say vomit. That's just burned in. I don't know why.
Yeah. That kind of makes me want to puke actually, that you can't say puke anymore. I feel bad for you.
I don't want to deal with the vomit. So
been there, done that.
Yeah.
So fractures can be kind of classified as open or closed fractures. And so open is going to be where there's a break in the skin. Because of that fracture, closed is going to be where it did not break through the skin, essentially. Speaking of kind of stories with mechanism and all that, I had a call in my medic internship where multiple car accident, I got put on a patient as my preceptor and the EMT that we were with went to the other patient. So I'm doing my thing. I talk to my patient, holding C-spine. Second ambulance shows up. I pass off care, go over, and they had loaded our patient onto the gurney. And they're like, oh yeah, she has, she was seatbelted, all the normal stuff. I think she's in like a seat collar. She's laying there on the gurney, blanket on her. They're like, yeah, she had like a small laceration on her leg. We bandaged it up, no big deal. Everything's good. And so, I didn't do a super thorough assessment, which really the whole point of the story is like, do your own assessment. But I didn't do super thorough assessment. We're transporting her to the hospital and she's complaining about leg pain and everything. And, I'm an intern. So I was like, can we do fentanyl? Like I got really excited, right. To go and do some pain meds. And so we gave her some pain meds and she's feeling a little better. And I kind of looked at it and I saw it was just like a little, like half an inch, like small laceration that I just assumed was a piece of glass or something. Yeah. And we get to the hospital and we move her over and we're kind of looking at her, me and the EMT, and we're like, her leg looks weird. And so like the more close I look, the more we realize she had a femur fracture. And
bone end.
The little bone end had gone through the leg, through the skin, and like had gone back when she was moved or something. So like it had opened and then closed essentially. But they didn't find that on their initial assessment. And I didn't do a good thorough assessment after. I should have put my hands on and recognized like, hey, this is shortened and all of that until we moved her, when we realized her leg was like her hips were this way, but her foot was like way off a degree that it shouldn't be able to go because her femur was displaced. Yeah. So I don't know what brought about that story, but definitely, kind of mechanism stuff. And, if you
open injuries.
Yeah, a little bit. You're right. Yeah. If you see those kind of things, do a thorough assessment, make sure you're doing your own assessment for these things as well. Don't just take whatever somebody says as Bible. But yeah, it could be a really major injury with a minor open. That was still considered an open fracture because it did break through the skin.
Which I think there's an important delineation here too with like open, like is technically an abrasion on a fractured side, an open wound or an open fracture. In my mind, it's not, because skin's still technically intact, right? But that first dermal layer is gone. So that's one I get questions on quite a bit. It's anytime the inside world sees the outside world. They're not designed to meet, right?
Yeah.
So that would be an open. But to Chris's point, to his story, trust your instincts a little bit as a human being with orthopedics. Like there was a femur fracture on one of those electric scooters that people can rent. And when we walked up, this gal was kind of, only way to describe, I think I've told this too, is she was sitting like a princess. And like she was wearing like a dress, just came from a wedding, but it was like something does not look right about you. And then sure enough, her femur had a nice 30-degree bend in it. It's like, oh yeah, that would explain it. But she was just all propped up and was like, and she was in this area and she smelled good, which that doesn't happen very often in this side of the world. So it was like pleasant actually. Sorry about your broken leg. But yeah, trust your instincts when it comes to deformity. If it doesn't look right, it probably isn't.
Yeah, for sure. For sure. Yeah. And get your hands on. Don't just go visual. Make sure you're getting your hands on and really assessing those things, especially if it looks weird. Touch it.
Especially if you got to write the chart too. If you're in charge enough to writing the chart, you need to be touching them, right? You can't just rely on other people. Like what's the legal, if you didn't do it, it didn't happen. Right?
If it's not charted, it never happened.
Right. But even like if someone says they did it and you can't verify it, that's still going to go against you. Right. So just get hands on.
Yeah. So another term you need to think about when we're talking about fractures. So we got open and closed, and we have displaced and non-displaced. And so a displaced fracture is a fracture that it is no longer in its anatomical position. Essentially, is, I don't know if you have a better way to describe it. To me, that's how I think of it. So
no, I would agree. If displaced would be, your arm should normally be in a straight line and it's taken a hard left turn, right? Like that's going to be a displaced. That's not where it should be. Yeah.
Some sort of deformity,
Correct.
something like that, is going to be displaced. So, if you just have like a small crack hairline type fracture, it's probably not displaced. But if you have a full fracture and it's shortened and you have that big bump, that's typically going to be a displaced fracture.
Yeah. Yep.
You want to talk a little bit about the different types of fractures?
Yeah. And I think this is, each one of these will have a different kind of role. So I'm just going to say them and then we'll kind of go in on each one. So we have comminuted fractures, epiphyseal fractures, green stick fractures, incomplete fractures, oblique, pathologic, and spiral. Now, each one of these comes with a different circumstance, and some of them, one in particular, is something that we need to view as a bit of a red flag in my mind. But starting with the comminuted, right, that's going to be a fracture in which the bone's broken into more than two fragments. I think of it like the flail chest of broken arms.
Okay.
Right? Like
that makes sense.
They broke a chunk out rather than just one isolated clean break. Think about it like if this is going to be maybe graphic imagination land. Someone was to step on your arm and your arm folded upward while they're stepping, right? You're breaking one side then the other, causing that movement. Now, epiphyseal is one that we typically will see more in children, mostly because they're growing, right? So an epiphyseal fracture is going through the growth plate. That's why, like, if you ever see people who, now this is not all of them, but if you ever see people who have like the one really tall shoe and one really short shoe, sometimes when they were kids, they ended up breaking through the growth plate in their knees. And so then their legs just, or wherever on the appendage, and they just don't grow the same.
Yeah.
Right. So it starts to throw everything off on that one.
Yeah. So, those growth plates are typically going to be on either end of the bone.
Yeah.
So that to keep that, just remember that those are not typically going to be in the middle of the shaft of the bone, because it doesn't grow from the center, it grows from the outside, right? So, and thankfully, most of the injuries are going to be like mid shaft kind of injuries, just because that's where the weakest point of bones is. But yeah, for those growth plates, not really anything we can do about it. Is just something to note and really make sure you're splinting well to hopefully allow it to heal properly so they don't have long-term issues.
And epiphyseal can also be one of those things, like it was a spiral fracture that spun into the growth plate. So it's kind of a blending of maybe a couple types of fractures. Now the red flag one, that's the green stick fracture. So incomplete fracture passes only partway through the shaft of a bone. We typically see these in kids. If you think about like sticks, right? If you break a normal dead branch, it's going to break. But those green sticks, they peel, right? And so that's the way that kids' bones, because they're so much more pliable, that tends to show up. Now, looking at it from our perspective, because we're line of sight medicine, it's not going to be one of those things of like, that's a green stick fracture, right? But where you got to be concerned is more so is like, read the mechanism, listen to the story, because if the story's got some red flags and not lining up in your mind, this is where you got to kind of keep child abuse in the back of your mind a little bit. But yeah, that is going to be the most typical way that kids will break their legs, or but not legs, bones. Incomplete is exactly what it sounds like. You're not breaking a bone all the way through. You got basically a crack halfway through the bone. Still a fracture in the bone. We can still have swelling, a similar presentation, probably going to be a non-displaced at that point. But definitely something to keep in mind. Now, oblique is where we tend to see our opens. So oblique fractures, instead of it breaking, like if this is a bone breaking clean in half, we break at an angle. So now we have two sharp bone ends.
Two knives, essentially.
And they're wicked sharp. They'll definitely get you. And another thing too, even as a provider, is if you see that sharp bone end coming through, careful with yourself, because you could cut yourself on these bones. They are very, very sharp. Yeah, anything to add on that?
Yeah, man, that just would be what a story, right? Like, hey, you hear about Wade? Yeah, when his colleague cut his arm on the dude's arm bone.
Yeah,
it'd be a pretty good story.
Blood brothers. Yeah, 100%. Pathologic, so that's just diseased bone, right, or weakened bone. Typically, like the go-to example is osteoporosis.
Yeah, elderly folk that are losing that bone density and that bone mass and all of that. Like bone density is so important for this stuff, and that's how you see, you got like Ray Williams, who most if you guys know who Ray Williams is, cool, you're probably pretty strong. He's super strong, guy that has squatted over 1,000 pounds raw, right? Like the weight that you and I could put on ourselves and would literally crush our bones.
Yeah.
That's how you have these strongmen, these powerlifters, all these guys, and why it's so important for elderly people to go and walk and lift weights, because you're breaking down those bones with little microfractures that regrow to make the bone more dense. And so that's what we're typically going to have if we're young, we're active, we're out there, we're going to have the good bone density, we're having a good diet and all those things. Where your elderly folk or other people maybe that are malnourished, they don't have that bone density, and so that's what this is talking about. For whatever reason, they don't have those dense bones, and then a break that shouldn't happen for you and I would happen because their bones are more brittle and don't have that good density.
Right. They're essentially, like, if you think of a bone as like a normal healthy bone at 100%, they're going into every situation with a 75% quality bone. So the likelihood of fracture goes up, and that's, and we'll probably get to it, but especially with old people, when it comes to fractures, and kids for that matter, when it comes to these broken bones in these people, it's a math game. It's statistics, right? Like old people, balance changes, especially if they have things like diseased bone. The likelihood of true injury is going to increase if they fall a lot. The more you fall, it's just math, right? Like if I fall 100 times a year, I'm likely going to hurt myself at least once, rather than your typical healthy person who falls, I don't know, once to twice a year, maybe, right? Like,
or little kids, a 6 foot tall 75-year-old man is falling from 6 feet.
Right.
A 2.5 foot child is falling from that short distance. And so also just kind of the math and the physics of it, that like little kids are less prone to get injured for lots of reasons, including that the mechanism is just less because they're smaller. So the little baby that falls on their butt 100 times a day as they're learning to walk, that's a 4-inch fall. Right. Where, grandma falls, that's 2 or 3 feet onto their brittle bones, and they're much more likely to break.
Yeah. And kids are also in a weird kind of phase. Like infants, for example, I'm learning so much, don't have kneecaps because they're on their knees constantly, so they're reducing risk of fracture just evolutionarily. I think it's kind of an interesting thing. But yeah, pathologic fractures definitely are something we need to ask about. Now, it's not going to be one of those things you can point out often. If it's something like maybe like rheumatoid arthritis, potentially that's going to be but that's more diseased joints with implications to bones. But osteoporosis is the most common one.
Yeah. And I would say for a lot of that, just kind of look at the patients, do like a good social assessment. Are they active, or those kind of things really lends itself to telling you kind of what condition they're in with the likelihood of osteoporosis. So, if you have the 90-pound grandma who just, sits in her chair all day long watching Matlock, like that's going to be a higher risk than, the same age, same height that weighs 15, 20 pounds more, that eats really healthy and, goes to the mall every morning and walks the mall, right? Like
Right.
they're much less likely to have those bone density issues, the osteoporosis, all that. Those pathological fractures are much more less likely in those more active, fit people.
Yeah. And then this is kind of derailing a little bit from the fracture types, but like people who are morbidly obese, right? Like that's another, Chris was talking about bone density. If someone weighs 600 pounds, just walking is putting strain on their bones in their body just because of their own weight. So, I mean, I don't know if you've ever had it, but I've had patients where it's heavier set folks. And it's like, well, what happened? I was just walking and I kind of just twisted weird. And then their ankle is not go in the normal human direction.
Yeah, I had a guy, and it was gnarly. Man, this is a story time for me.
Yeah.
Who actually pretty close to here too, was bringing his groceries in from home, and very overweight dude, probably 300 pounds, older guy, and just kind of rolled his ankle. And he thought he'd just like sprained his ankle, no big deal. But his neighbors were kind of freaking out when we got there, and it was. I don't even know what to call it. I guess an open fracture somewhere in the ankle, but like he almost tore his foot off, like legitimately. When we got there, I was like, this looks like it was like a partial amputation. Like
Dang.
At least one half of around his ankle was like the skin was torn and open. And he was just a big, heavy dude, and he rolled his ankle, and all that weight and just how he rolled it just kind of tore it and broke his ankle. But he had diabetes, and so he had really bad neuropathy, zero pain, didn't do any pain meds, anything. We put him on the gurney, and we took a short board because I didn't want his floppy foot hanging off the edge of the gurney to like flop and tear more. So we put a short board to like lengthen out the foot of the gurney to give a little more space after we put on, I think we put him maybe a vacuum splint. I don't remember how we splinted it, but it was all splinted and everything. But I was just so nervous. I was like a new medic that bumping down the road, it was going to further separate it out. Cause I genuinely, as we walked up, was like, this dude, and his neighborhood put a belt on his ankle because he thought it was amputated. It was gnarly. Dang. And it was just a really bad open fracture. And I think a lot of it just came down to just he was very overweight, and just, the force of that on that ankle with all of that weight pressing down just really, really tore it. And
that shearing force.
Yeah. Even better, real quick, even better.
Yeah.
We went on him again a couple weeks later, because his sutures and like the laceration, all that site was opening up again, because he was supposed to be off his feet, but he didn't like getting around on his scooter in his apartment. So he had been walking on it. And so we had to take him to the hospital again because he had popped a bunch of his sutures and it was starting to reopen.
And he had that neuropathy, so he doesn't even know.
Yeah. He's like, yeah, it feels fine. Well, dude, you like tore your foot off and you felt fine. So you're not the good judge of it.
I mean, I had a diabetic who ripped his pinky toe off. Essentially, I made the mistake of pulling his socks off, and he's like, yeah, I fell. It's just been kind of weird balance. And then, I was like, let me see your foot. Cause he's like, I stubbed my toe a few days ago, and his pinky was like not on, which also is like, how did you not notice this, buddy? Like these socks are either really old or, not going to get into that. But big takeaway of that is going to be, get a good history, because things will lend to the story, right? Like if he's numb completely from the knee down and he breaks his foot off, he's not even going to notice. Right?
No, and his pain levels and our OPKRST is not going to mean much because he doesn't even know.
Yep.
Those patients don't even know, right? Your pinky toe guy, my ankle guy, they just don't know. Because they just have the bad neuropathy.
Yep, pain's subjective. Back to it. So spiral fracture. So fracture caused by twisting force causing an oblique fracture around the bone and through. So essentially it spins its way up the bone. I had a buddy when we were kids actually ended up having a spiral fracture of his tibia. And we were playing football, and of course he was down. So then my really skinny friend jumped on the pile, as one does when we're children. And then he's like, yeah, it's just a sprain. And then he was in like a full leg cast for like 6 months or something like that. But that one's, and he was at risk of that epiphyseal involvement because it was spiraling close to his knee. So that's where I'm saying that these things can blend together sometimes. And an analogy back to epiphyseal while I'm thinking about it, trees grow from the top, right? Like if you look at a brand new tree, the bud at the top is what causes growth. It's kind of the same when you look at our bones. It's from the furthest point, right? If we're going more distal, so tip of the knees is what grows outward, just for your knowledge. And the last one, transverse. That's just your clean cut through and through. That's a broken bone.
Yeah, that one's pretty straightforward.
Yeah.
But yeah, if you're a student, make sure that you have these pretty well down. Are we going to be able to recognize one from the other in the field? Probably not. But I promise you that National Registry might like to ask you these questions. So, yeah, make sure you're aware of the different types. Realistically, you need an X-ray, which we at this point don't have. But honestly, I could see it in 5 to 10 years in EMS that us being able to like throw up an X-ray.
I heard of a system rolling out
that.
mobile.
Yeah, it doesn't surprise me. Whether we can interpret them well is a different story, but AI might be able to do that in the future. So we might, this might be more relevant in the future, but for actual practice. But for students and everything listening to this, definitely you might see this on like a National Registry testing question. So be aware.
Yeah, your bigger takeaways in the field is displaced, non-displaced. That's really the big one. And then maybe green stick if it's a kid, and then more than likely oblique if that bad boy is shooting through skin, you're going to recognize it.
Yeah.
If you're curious about what a good open oblique fracture would look like, this is an old sports injury, but Kevin Ware, he was a Kentucky player. He broke his leg bad, and he's got an oblique fracture. I saw a bunch of memes. One of them had Rafiki from Lion King on the end of it, and that's burned into my brain. But yeah, if you're curious what that actually looks like, that's a good example.
Yeah, we won't be putting that in here because I don't want to look at that. So I've seen enough.
Yeah.
And then another thing with green stick too about like recognition, like normally deformity is going to be like the bump, right? Or like an angulation. I've seen kids where it just looks like the bone is bent. Like it's not so much that it's angled and, like a 45 degrees. It's almost like a swoop, right? It's like a curve. And that can happen with those green stick fractures, that it looks almost like a parentheses instead of a straight up and down.
Right. No lightning bolts, just a slight bend on it.
Yeah. Cause there's a very obvious like, oh, you know what I mean? Like when it's that question mark at the end of the person's arm.
Yeah.
But these are just going to be a little bit, you need to be able to recognize that based off mechanism.
Yeah.
Be looking for it.
Yep.
Other things we can look for to decide if maybe we think there's a fracture there. Obviously the big ones are going to be deformity, right? So do it look normal or not? If it doesn't, then maybe we have a fracture, and it could just be swelling, but I generally will go if there's some good deformity. It's probably not just swelling. It's probably something beyond that for sure.
And swelling can be pretty extreme too. Like it can be misleading, but if the mechanism lines up and the appearance is a little bit wonky and it's going to be swollen and it still looks wonky, honestly, we'd rather over triage and be wrong. Let a doctor call you dumb. Don't make the mistake yourself.
Yeah, for sure. And then, so tenderness is going to be another one, right? On palpation, does it hurt? So pain, tenderness, all those things, especially as it's touched on palpation. And so you might see some guarding because of that. So especially like a clavicle fracture, so like a collarbone, typically people are going to be holding their arms up and in to support that because it feels better. So you might see some guarding if a patient has a fracture there.
Or even like forearm fractures, they tend to hold their own arms. I've noticed just after seeing people destroy their body over years, that anytime anybody really breaks something, they tend to be holding on to it. Unless it's like their foot and then they're just like, don't look at it because it's not on my leg anymore, right? But like for the most part, when we say guarding, it's just holding it, right?
Yeah.
Self-splinting.
Yeah, exactly. It's taking like the weight of gravity off of it, essentially, is typically what they're going to be doing.
Yeah.
Or like, rib fractures are going to have their hand on it guarding to try to stop it from moving or those kind of things. But yeah, if you're somebody's consistently holding an injury, I would be highly suspicious there's some sort of fracture or something going on.
Got to ask some questions.
Yeah. Swelling, bruising, those kind of things. You're going to see crepitus, which if you're listening to this, you probably know, but crepitus is like the feel and sound of broken bone on broken bone. And
it's crunchy.
It's crunchy. Yeah. If it's not technically crepitus, but I always think of like if you've been first on CPR, like that feel as you're kind of breaking, you're not actually breaking the ribs, you're breaking the cartilage that holds the sternum to the ribs. But that kind of feel and sound a little bit crepitus is what it makes me think of.
Or if you've ever broken your toe and taken a step, you've felt crepitus before. Promise. Yeah, just that crunchy. It's just bone ends touching bone ends where they were fused once upon a time, and then you live life and something happens.
Not your guy though, not your pinky toe guy. He didn't feel anything.
No, yeah, I still think about that from time to time. It's like, that was skin, brother. Like there's even everything was gone. It was yucky.
Crazy.
False motion.
Motion. Yeah. Did you ever meet, there's a guy, at least he was around here locally, that had broken his
shoulder,
humerus.
Yeah. And he swung his arm.
Yeah. And he could swing his arm in a weird way. He had false motion. So, our arms should move these ways, and if you can wave the wrong way, then there's probably a fracture there. So yeah, that's funny. I wasn't sure if you'd been around long enough to have met that guy.
I met that guy. There's another guy who had a shoulder that would like swing his arm really weird. And I was like, what's going on with you?
Yeah. Yeah. There was a guy here locally that had broken his humerus and never had it set and fixed. And so he had figured out how to like bend it with his muscles so he could like go this way and this way. Like he could move his humerus the way it shouldn't. Just his brain had figured it out. It was kind of fun with new people too, to be like, hey dude, can you do the thing? And then go, what? You know, like
it did. It
was
first
weird.
Time.
It was weird. It would throw you off. But that was a long-standing thing. If there's false motion that's new, it's probably a sign of some sort of new injury.
If they have a new joint in the middle of a limb, that's false motion. Like another example, sports example, Anderson Silva, UFC, broke his shin kicking another dude's leg and his toes touched his knee on the same leg.
Yep.
That's false motion.
Yeah. Yeah, I know. You know, this. I feel like this is one of those things that pretty profoundly, when you're new, is really cool, and then when you've seen it a couple of times, you're like, I never want to see that again.
Yeah. Or you hurt yourself enough times, you're like, I don't want to look at this anymore. Yeah, that's fair.
Obviously, exposed fragments would be something. If you can see the bone, it's probably broken. You know, you probably shouldn't be there. So.
Yeah, and then another thing with fragmentation is that if you see fragmenting bone, like visibly through the skin, there's probably chips free floating. My wife ended up breaking a section of bone off when she was a kid, and she actually had a surgery a few years ago to get a bone chip removed because it was working its way, just basically shearing through ligaments in the back of her knee. So yeah, just keep that in mind. If you see it, that's what we see. That x-ray is going to be much more telling.
Yeah. Did she keep it? I feel like your wife would keep it.
I wanted to, because I wanted to make something out of it. The doctor
cool
kept
jewelry.
it. Yeah, dude. Like, this is my wife's knee bone. Yeah, nope, not interested, apparently. They wouldn't let me keep my wisdom teeth either on for the same reasons, but
that's weird.
Neither here nor there.
Another thing is going to be a locked joint. So, you know, that's broken. They just can't move it because it's broken and it's locked itself out is something else too.
Yeah. Or like frozen joints is another way you'll hear that, like frozen shoulder, which there's a lot of reasons for frozen shoulder, but that's like an example.
All right. Anything else about fracture? I think we kind of.
No, I just want to double down. A fracture is a broken bone.
Broken bone.
If you're going to argue with people, argue with the right facts.
So other things we can talk about is going to be a dislocation. And so that's going to be at a joint, right? You can't break a joint. You can dislocate a joint, but you can't break a joint. And so that's going to be a disruption where the bone ends that are supposed to be kind of in contact or in line or no longer in contact or in line like they're supposed to be.
Correct.
I'm trying to think if there's any. I feel like there's not a ton to talk about with dislocations.
I would say one, we don't set. We don't reset them.
Yeah.
Reduce is another way you'll hear that. Anywhere you have a joint can be dislocated, right? So shoulders, knees, ankles, elbows, wrists, all of them are on the potentials there. Big takeaway, I think, with dislocations is that it's not like you see in the movies where someone's got a dislocated shoulder, they pop it back in and they're good to go, right? The likelihood of underlying damage is incredibly high, which is why we don't reset them.
Yeah. There's some that I think are pretty simple. Like I know locally as paramedics, you and I, we can reset a laterally displaced patella and then nothing else because that is such a low likelihood of any further damage. Right. But if we even suspect that there's any fractures below it or anything, like we're not going to touch it.
Yeah.
But yeah, outside of that, like you really need to have scans and everything. Like there was a bit of a controversy recently in MotoGP racing. One of the guys dislocated, I think it was recently, maybe I'm just old and it was a while ago, but dislocated his shoulder and like somebody on one of the medical crew on scene just came up and kind of popped it right in. It's like, you don't know, like he just crashed a motorcycle at 100 miles per hour. You don't know what else could be going on.
Right.
And there's a lot of vasculature. There's all sorts of stuff in there. There's nerves, there's veins, there's arteries that could be sheared or could get sheared by you trying to place that bone, that joint back into place.
Right. And especially like shoulders, like we have that big subclavian artery running through your collarbone that feeds to your arm. If you pinch that and tear it, that's a problem.
Yeah.
But even like, so I think I've told you this story before, lateral patella dislocations, like Chris said, are very simple to reset, but there can be complications. I had one patient in particular, like normally when they dislocate, they kind of just slide to the side and you just pop it back, right? Well, his slid down, but then popped popped up horizontally. So like when I was palpating, I felt the ridges underneath his patella. And so that was one where it's like, this is not that simple. I gave it one go. We gave him a lot of ketamine. I gave it one go, and I was getting nervous because at a certain point, it's like, well, we don't want this to flip over, because if this flips over, now we've got torn ligaments and on top of whatever damage to this bone, which ironically, the doctor, when he fixed it, it was one of those things of like, we hung out because it was like, this is weird. He actually had to further dislocate it to pop it back because he had to push the whole thing down. So this poor kid, and for the viewers, just remember when you relocate something, like there's a great amount of force that goes into that depending on the joint. With that one, I was pinning the kid's ankle down and I felt the reverb of vibration through his bones as that slid back in place. And it's loud and it can be intense sometimes. So just keep that in mind. These are not always straightforward. Just splint them. It's your go-to.
Especially at the EMT level, splint them. I know looking through the book and stuff and so maybe there are places that have protocols that it did mention in the book that maybe medical control will talk you through reduction of a dislocation. So, I mean, if that's the case and it's within your scope, then obviously it's something you're able to do. Just make sure you're trained on it. You know, we have that one dislocation that we can reduce, but we're trained on it. We know how to do it. And
we're also close to a hospital. Like, you know, if we work with the smoke jumpers, they're trained on how to relocate joints because they're in the middle of nowhere. Yeah. Right. Like it's a figure it out or you're going to lose a limb potentially. Right. Like that's maybe an extreme example, but that's the thought process.
Yeah. And when we're talking about dislocations, sometimes they will self-reduce and you need to be aware of that as well. So again, that good history, that good story. If the patient says it looked funny and then I moved and I felt it go back, like you need to chart that. You need to be aware of that and they need to be seen. Even our patients that we would reduce those patellar dislocations, you're typically going to go to the hospital with me afterwards because they need to do x-rays. They need to make sure that nothing else further did happen.
Yeah. And there's another term we can use for that. It's called subluxation. But like if the shoulder joint is pulled out and then snaps itself back in, like, you know, someone grabs your arm, pulls, and then it pops back. That's a spontaneously reducing, essentially.
Fractures and dislocations can happen at the same time. Sometimes it's really difficult to tell one from the other. You know, like it's about like a hip can be kind of difficult if a hip's dislocated or fractured. And I don't know that we'll talk about it today, but hip fractures are kind of a misnomer because it's actually your femur that's breaking. Again, joints don't break.
Correct.
But some of them can be difficult to tell the difference. For our purposes, though, it doesn't really matter. We're going to splint and go to the hospital. So, you know, if it's obvious, it's obvious. Otherwise, don't worry too much about it. Don't lose sleep over it. Just splint, get them in position of comfort, get them where they need to go.
And then keep people who are the random lay people like, I'll just put it back. Try to stop them from doing that. Like an example, when I was a kid, one of my teammates, we were playing a game and he fell and he ended up dislocating his pinky and it was at a hard 90-degree angle. And one of the dads on the team was actually a fire guy. He was a fire captain. And he's like, oh, I'll just reduce it now. And it's like, no. And thankfully he didn't do it because he actually ended up fracturing the bones around that as well. So this is why we don't. Just once again, there's complications that could come with it because we're such line of sight medicine that we just don't have all the pieces in front of us.
Yeah. Now, maybe down the line, there will be. Maybe this will change.
Yeah, hopefully. That'd be cool.
Signs and symptoms of dislocations, I don't feel like are typically much different. You know, you're going to have those deformities, those kind of things, maybe more likely to have some numbness or tingling if maybe there's a dislocation that's pushing on a nerve bundle or something like that. So that's definitely something that can happen, or some issues maybe circulation wise. You might see that. So, but for the most part, pain, guarding, tenderness, swelling, deformities, those kind of things.
Yeah, I might, and then an increase in that like frozen joint, or, you know, I don't want to say this, the joint that's not moving correctly as it should, right? Like, duh.
Working our way down. So dislocations are going to be the bad. And then we've got sprains and strains, and sprains are going to be worse than strains, but they're kind of more or less the same thing at different degrees.
Different structures a little bit.
You want to talk about sprains?
Yeah, I'll talk about sprains. So sprains is going to be a joint problem, right? The most common example, which I've lived more often than I care to explain, is ankles, right? Like you roll your ankle, you bend the joint the way it shouldn't go, but it's not just bending, right? It's like bending and then doing a little more, right? So like you're just put your foot on the side of it and then continue to step down and push that. You're eventually going to start damaging ligaments. That's going to be the big ones. As well as the capsule. So around each joint, we have a bursa capsule. And so you can start damaging that bursa as well. But yeah, big joints, any joint, once again, can be sprained depending on the mechanism. But the common ones, knees, shoulders, and ankles, pretty common. Wrists in certain demographics. When I was in high school, a lot of the cheerleaders had the things on their hands a lot because they were doing back handsprings, so their wrists were just starting to. I had a couple of sprained wrist friends growing up, right? So like any joint can be there. Now, realistically, when it comes to signs, symptoms, guarding, yeah, pain, tenderness, all of the things, the joint might feel more unstable because you have essentially taken those rubber bands and overstretched them so they're not holding the same. But the big identifier is going to be swelling and that ecchymosis, or the pooling of blood, right? Like if you've ever sprained your ankle before and your whole foot turns purple and green and blue and all the rainbow colors, right? And it's just huge. That is a pretty go-to identifier, which commonly, in my opinion, gets mixed up with deformities. People see that massive swelling like, that must be a deformity. Line of sight medicine, we don't know.
Yeah. Really, real bad swelling, like we said before, can be obviously easily mistaken for deformities.
Yep.
So yeah, that's sprains, and then strains are kind of be the same thing. It's those ligaments that are pushed where further than they should go, where it's just a lower level, and typically a sprain might have like a torn ligament or something like that, where a strain won't. Yeah,
and strains tend to be a lot of muscle involvement as well. But yeah, and then for the lapers here, ligaments connect muscles to bone, tendons connect bones to bone. That's an important delineation there. Like your ACL or like all your knee ligaments, right? They hold the bone or the structural integrity. The ligaments is where the muscles attach, which allows the motion of the joint. So typically with strains, it's going to be a muscle that starts affecting the ligaments and then could potentially have like micro tearing or things like that. But I don't think people typically call an ambulance for this one. I haven't ran into a lot of strains necessarily. Maybe on top of like compounded with whatever else was going on.
Yeah. I mean, I don't know. We've ran a whole bunch of stuff. I'm sure we've been on that before.
Probably.
And then the notes have amputations, which I guess falls within like a
technically
orthopedic?
It's orthopedic.
Yeah.
It's not there anymore.
Yeah. And so that's pretty simple. It's when part of the body is severed from the rest of the body, essentially.
Yeah. Your hand was on your body and it no longer is.
Yeah. Did you have any amputations when you're out in the field?
No. I didn't have any amputations. I got dispatched. This is not the same. It was a guy who got cut in half. We got canceled pretty quick on that one. But a buddy of ours had a good amputation. A guy crashed his motorcycle into a guardrail and essentially ripped his leg off. The reason I remember this story mostly is because it was my favorite top 10 favorite radio traffic I ever heard. Because, where we work, if they tell you to go to a certain channel, everybody's like,
follow.
I'm going to listen on what's going on. And then the supervisor's like, yeah, can you tell PD to bring that leg with them? It's like, oh, so they forgot something important here. Which the kid ended up surviving and good outcomes out of it.
Were they able to reattach?
No. Has a prosthetic. One of our students is actually a good friend of him.
Oh, really?
Yeah. So I kind of got the full.
Okay. I actually think I remember the story. Yeah.
Yeah.
Yeah. I never went, decade plus in the field. I never had, I had like kind of partial amputations or that kind of thing, but I never went on a full amputation. They're not very common. They're very rare. And maybe there was like that kind of stuff that I was on where it was just, we didn't even work somebody like major trauma, where we didn't even work the patients. But I feel like typically just not a common thing that we see.
Yeah. I'm thinking about it. I've had a few. One in particular was a dead on arrival. And I was asked to feel pulses on him. And the way this was all set up, he was in a crashed vehicle. They're like, feel pulses. And the only thing I could see was his foot, but his foot was hanging on by like some skin. So it was kind of one of those like, where, like I'm trying, I got nothing, boss.
I can see that a pulse wouldn't mean anything because it's not connected to the rest of the leg enough.
Right.
Yeah. You need arteries for pulses. There's no arteries connected to this foot anymore.
It turns out those are important. Who would have thought? Yeah. Yeah. But our go-to treatment, right? Like bleeding control. That's really all you can do. Bleeding control. If you can, take whatever limb you can with you, because if it's like within the first 20 minutes to an hour, they can actually surgically reattach.
Yeah, and one thing that I have always found really interesting is typically amputations bleed less than you would think. It's not like you have like a garden hose that you cut in half and the water's just going to keep going, because our veins and arteries are kind of elastic, and have, will be affected by sympathetic response and all of that. Typically, there'll be heavy bleeding initially, and then all those things will kind of snap closed, and the bleeding will be much less than you expect it to be. Not always the case, right? There's a very famous picture from the Boston Marathon bombing. I don't know if you know what I'm talking about. There's a guy in a wheelchair, and there's a guy, I think it was like the cover of Time, is pushing the wheelchair, and he's pinched, the femoral artery is just out of his leg, because he had lost his leg, and he's pinching the femoral artery, which is it's a gnarly picture. But so not always the case. You may have to, you do have to manage bleeding control, but typically will bleed less than you think, at least from like the soft tissues.
I mean, this is maybe a little presumptive here, but like, I would be of the opinion if I showed up, and even if they're clamped, self clamping, I'm probably throwing a tourniquet on still in my mind.
No, yeah. Well, this was a big MCI event. Like,
that's different.
That one specifically, this was a bystander. That just, I think was like, had done like combat medicine and just like pinched it. It was, we'll look it up after. It's pretty cool.
What? That's good involvement, man. This is why it's life skill stuff. Being an EMT basic is a life skill. I can't be a paramedic if I don't have paramedic stuff, but I can make a t-shirt a tourniquet, right? Like, so.
Truth bombs on the old Basically EMS podcast today.
Preach.
Yeah. I think we're kind of coming up on the amount of time that we were shooting for. And so I think maybe we'll just have to reconvene at a later time to talk more specific injuries. So like I said before, this is kind of a general thing, just talking about the different types of orthopedic injuries, and kind of the severity and what to look for with those. And we'll jump into it more specifically to talk about clavicle fractures and hip fractures and pelvic fractures and all that. Maybe our next trauma-based podcast that we do.
Yeah. And I think, well, we can get into more specific splinting and treatments, but I just want to get it out now. Splinting is a concept. How you splint is going to depend on where you work and what they have. As long as you know if it's a broken bone, you need to isolate and splint the bone as well as the joints distal and proximal, or above and below, and then inverse for a joint. If the joint is wonky, right, it's got a dislocation, maybe a fracture in the area, you're going to splint the joint as well as the bones above and below. Supporting structures. Outside of that, how you do it is really up to you and what you've got.
I always think about a bridge, right? If we have a bridge that's spanning a river and the middle of the bridge breaks, if I just put some tape around the middle of the bridge, it's still going to fall, right? I need a structure that, and even if I put, a piece of metal over that, it can still bend and bow and break again, right? I need a piece of metal or something, right? Some sort of structure that goes from beyond where that bridge is attached to the land on either side, and then tie all that tight together. And that will be those anchor points on either side. Yeah. And so that's why when it's a bone, we need to go to the joint above and below to anchor that bone either side, because if we're just this wide, it can still, leverage. We need to have it fully stopped on either side. And a joint's the same way. We need to anchor it on either side of the bones so that it can no longer flex.
We are mimicking stability. That's all we're doing.
Yeah, we're just adding stability. And I feel like splinting is so overlooked in the field. And splinting is really important because it really will prevent further injury. It can stop. We talked about all those structures that are held within the shoulder or in these joints. We don't want those injured, broken, knife ends to be moving around and causing soft tissue damage, affecting nerves, affecting muscles, affecting vasculature. So don't overlook splinting. And granted, if somebody was thrown from a car and they're not breathing and they have a pneumothorax, and are we going to splint the ankle on that patient? Probably not, right? Like big multi-system trauma, it's going to be low on our list. But in general, if we can take the time, go and splint. And like Wade was saying, splinting is not something that we are black and white teaching you do this. We're teaching you that main concept of to stop that motion and hold it securely. How you're going to do that is up to you. You want to use a pillow. You want to use a SAM splint, cardboard splint. There's
yeah.
a ton of stuff out there that you can use.
More and more every day.
Yeah, and more cool stuff out there that you can use every day. So splinting, get really comfortable with your method. Have your method down. Some people really like one thing over the other. Neither of those are wrong. Just be really good at what you're going to do.
Yep.
And know that there are times like splinting a humerus fracture is really hard. It's really weird. It's not easy, right? So go into it knowing I might need to get creative and be ready to be creative with it. Just following those basic concepts.
Yeah. If you can MacGyver a situation, just knowing what you like, knowing where I need to stabilize, you just get, like Chris said, get creative. And some of it's sometimes just positioning in the right way, you know?
Cool.
Yeah.
Any closing thoughts on orthopedic injuries summary?
Well, think about time of year, right? Time of year is going to play a role into our orthopedics. That would be a big one. 100 most dangerous days of the year is summertime, and then wintertime we got ice, depending where you live. So it's going to be something that you're never getting away from. So like Chris said, take the time, splint it, do the right thing. It's only going to help your care later, as well as set the doctor and the patient up for success. Yeah.
And kind of tacking onto that too, like know your area and know, you know, if you live close to a ski hill, you're probably going to see a lot of leg fractures because of skiing, right? Or knee injuries are going to be really common in skiing. So, you know, know your client type, know your clientele that's around you. You know, if your district has a skate park, you'll probably be going there for falls, and you might have wrist fractures because skaters fall on their hands or whatever. It's good. It's a good idea to know kind of what to expect and then train on that and be really prepared for it for sure.
Yes.
Or to know your client or your climate and how that's going to affect things for sure. Like you said.
Yeah. Yep.
Right on. Cool. So, hope that was helpful for people. Like I said, this is a much bigger subject than when I think I kind of thought when I was like, yeah, we'll just talk about orthopedic injuries. Yeah. It's like, well, we can go really deep into it.
Cut a lot of it out, and then we're talkers, turns out. Who would have thought?
Well, you know, I think they're fun stories.
Yeah.
Hopefully they're fun stories.
Yeah.
Sabrina made a lot of really good faces, which means that we're doing our job pretty well, I feel like.
Crushed it.
So yeah, if you haven't checked out the new YouTube channel, please do so. Please subscribe. Like I said before, we're not going to be posting this for very much longer on the Summit Healthcare Education channel. So that will be your only spot to find the video. I guess this video is on Spotify too, but if you want to watch YouTube stuff, we're going to be on that channel here exclusively coming soon. Otherwise, yeah, check it out if you haven't. We also, as always, are on Apple Podcasts, Spotify, anywhere you choose to listen to your podcasts.
Meet your podcasting needs.
Yeah, exactly. Yeah. You can find us there. So please do so. We've got lots of other cool trauma stuff, medical stuff, all sorts of stuff on the old Basically EMS channel. So
yeah, leave comments if you want anything in particular.
Yeah, hit subscribe, leave comments, all that stuff. Smash the subscribe button, smash, all that. And we'll talk at you guys here pretty soon. See you next time.
Bye.